Dear ladies and gentlemen, my name is Lukas Opatril. I'm from St. Anne's University Hospital in Brno, Czech Republic, and it's an honor for me to present here our work entitled Stress, Pulmonary Circulation Parameters in Patients After Heart Transplant and Cancer Survivors, a CMR study. I have nothing to declare. As for pulmonary circulation parameters, in several versions, using different modalities, they have been studied for decades. The latest method of assessing them is by cardiovascular magnetic resonance, or CMR. It refers mainly to time needed for blood to get through the pulmonary circulation, in our case from right ventricle to left ventricle, and CMR offers many advantages, one of the biggest being assessing stress parameters as well. They have a potential to reflect the function of the cardiopulmonary system as a whole, mainly systolic function of both ventricles, diastolic function of left ventricle, and pulmonary hypertension as well. For the sake of this presentation, we will be referring mainly to two of them, PTT, or pulmonary transit time, which is the raw time needed for the contrast to get from the right ventricle to the left ventricle, and PTB, or pulmonary transit beats, which is the number of cardiac cycles which is needed for it. As for patient selection in our study, we included patients after heart transplant, 49 of them, with no signs of systolic dysfunction or pulmonary hypertension. We then divided them into two subgroups, 41 without any signs of diastolic dysfunction as a subgroup A, and 7 with signs of diastolic dysfunction in subgroup B. We then compared them to a group of childhood cancer survivors, or CCS group, where we included 39 patients with no signs of systolic, diastolic dysfunction, or pulmonary hypertension by echocardiography. They were patients that in younger age went through chemotherapy, in most cases anthracyclines in 49%, the rest cisplatin and carboplatin. And why we studied patients after heart transplant? Because as already published by Professor Melusine from our department, up to 58% of these patients showed diastolic dysfunction only detectable in stress conditions. And therefore we hypothesized that these patients should have their parameters prolonged when compared to CCS group. As for methods, we used short-axis perfusion images in both rest and adenosine stress-induced perfusion stacks. On image A, you can see that we did a ratio of interest in right ventricle and left ventricle. From the data obtained, we then made a graph of signal intensity to time. And as you can see, as the contrast agent is getting through the ventricles, firstly through the right ventricle, the signal intensity is going up, and then through the left ventricle as well. The time between onsets of these increases then defined PTT, or pulmonary transit time, and the PTB was defined as number of cardiac cycles between these onsets. In the image C, you can see how on the first pass perfusion images, the contrast agent, in this case gadolinium of course, is getting first through the right ventricle and then through the left ventricle as well. Of course, pulmonary transit time is affected by heart rate. Therefore, we used heart rate corrected PTTC as well, which was obtained from PTT by simply using Bazzet's formula as a correction, which is used, for example, on a QT interval and in the EKG as well. As for rest parameters, as you can see, there were no significant differences in the PTT between the groups. However, in the case of corrected PTT and PTB, they were both significantly prolonged in patients after heart transplant when compared to CCS group. You can see a box plot of it there as well. For the stress parameters, both corrected and uncorrected PTT were significantly prolonged in patients after heart transplant when compared to CCS group. To sum it up, all stress parameters and from rest, corrected PTT and PTB were prolonged in patients after heart transplant when compared to CCS group, which points to subtle diastolic dysfunction. Stress parameters were lower than rest parameters, which at the time of this publication was in contrary to only published data and therefore was a significant finding as well. However, we must say that we expected higher parameters in the subgroup with diastolic dysfunction in compared to the subgroup without diastolic dysfunction after heart transplant. As you can see from the box plot as well, there are clearly trends of higher values in this subgroup. However, it does not reach statistical significance, but we have to say that this was highly influenced by the very low number of patients in the diastolic dysfunction subgroup, only 7. As a conclusion, assessing of these parameters is feasible. Patients with subtle diastolic dysfunction tends to have longer PTT and higher PTB. Changes are more prominent in stress conditions, and it offers a possible new stress test option. And I thank you very much for your attention, and I'm ready to answer your questions.
Thank you very much. So this paper is open for discussion. Okay.
Thank you so much. Wonderful presentation. Among the 48 heart transplantation patients, 7 was diastolic dysfunction. So I think, could you clarify the definition of a diastolic dysfunction in this case? Because diastolic dysfunction is such a spectrum from the impaired relaxation to the restrictive pattern. So how this define the 7 patients of diastolic dysfunction?
It was assessed by echocardiography using Doppler techniques, both from mitral valve assessment, E2A, and to tissue Doppler imaging as well, E2 E apostrophe. And the patients in the first group did not reach the definition of a diastolic dysfunction, and in the group with diastolic dysfunction, they showed grade 2 or higher diastolic dysfunction.
UVE prime greater than average 14 or 16?
In the group with diastolic dysfunction, E prime was E2 E prime was higher than 14. In the group
14.
Yeah, but in the group without diastolic dysfunction, the mean E2 E prime was below 8.
Yeah,
so
it was very tricky because in case we are included without pulmonary hypertension, so in diastolic dysfunction we have a combined index, not only UVE prime, TRV max, and array enlargement as well. But in patient of a heart transplant, not all, but most of the people have enlarged LA. And in the case, we excluded pulmonary hypertension, so we only rely on the UVE prime 14. Is it correct?
Sorry, I didn't understand the last part.
I think usually 2016 AHA-ACC guideline in case of defining diastolic dysfunction, ejection fraction less than 50, we included 3 indexes to define diastolic function. But in case of a heart transplant, it is a little bit tricky because LA usually enlarged. It is one of the components. And also in this study, we excluded pulmonary hypertension, but so we excluded the increased tricuspid regurgitation velocity. So among the 3 indexes, we only evaluated UVE prime. I understand. Is it correct?
Yes, it's correct.
Okay, if no further questions, so let's move to the last presentation.